Good morning. It is my great pleasure to welcome you to the inaugural conference of the UCD Leadership in Healthcare Network. 4 of us who have organised the conference here this morning are situated in Lecture Theatre 1 at the UCD Smurfit School, socially distanced and following all safety protocols. With the breaking news yesterday around the framework for restrictive measures in response to COVID-19, the context of this conference becomes even more important. However, the idea of the network was formed long before the pandemic. In fact, it was in February of this year that we invited Dr. Ronan, former Master of the National Maternity Hospital and UCD Alumni Awardee, as our guest to speak on the topic of leadership through adversity. On that day, none of us could have imagined the speed of spread of the virus to Europe, nor of the direct and indirect impact on our daily lives and on our health and well-being would be drastically altered within a single month. Changed utterly. The pandemic has been likened to a black swan, defined as uncertainties with a very low likeliness of occurring, but which have disproportionately big impact. Within our UCD Leadership in Healthcare Network, we want to consider the impact of the highly improbable. Today, we have convened many of our leaders across diverse sectors to reflect on our journey through the pandemic to date and to question what will it take to move forward globally, and most importantly, to collaborate and engage in cross-disciplinary thinking so that we may engage in critical and innovative thinking to reflect on a new path to ensure a better and safer future for all of us. This is the objective of the UCD Leadership in Healthcare Network, to convene diverse experts from the realms of health, industry, finance, the arts and culture, and sports to collaborate so we may think outside the box and think the unthinkable, so that we will be in a better state of preparedness for the next pandemic or indeed the next crisis. The pandemic has revealed that we can no longer afford to operate in silos. The pandemic may enable this de-siloing to take place so that we may have a stronger and deeper understanding and the integration of the public health framing of our economic and social lives. In our post-pandemic future, we hope to experience a narrowing of the gap between public health and business. Our network was inspired by graduates of our Executive MBA programme. Sinead Ryan, a pharmacist, and Dr. Knut Moe, a GP, who experienced the value of engaging with diverse experts to solve problems through multidisciplinary and cross-disciplinary thinking. Our aim is by the end of this morning's session, we shall have identified public policy implications and calls to action for our leaders and our Leadership in Healthcare Network to advance, so that we may think the unthinkable moving forward. In the most recent issue of the European Journal of Public Health, we already see a call for foresight studies so that we may build robustness against possible future negative events. In this context today, we are delighted to mark the commencement of a new groundbreaking collaboration between the UCD Smurfit School and Professor Mary Horgan, President of the Royal College of Physicians in Ireland and UCD Alumni Awardee. It is the first of its kind, bringing experts in medicine and leadership and management together. The public health crisis demands a considerable level of cooperation across sectors, across disciplines, and across experts. Now, more than ever, health and business need to forge ahead together for our society and economy to thrive. Hence, our new collaboration with the Royal College of Physicians of Ireland. Our conversation this morning is not only within the context of leadership through the pandemic here in Ireland. We shall also travel virtually over to Oxford University to hear from Associate Dean of the Syed Business School, Cathy Harvey, then to Queen's University Belfast to hear from Professor Mark Lawler, who has collected real-time data in the UK and Northern Ireland on the impact of the pandemic on our cancer care and cancer services. Mark is a board member of the European Cancer Organisation, the largest multidisciplinary cancer organisation in Europe, and is co-chair of their special network on the impact of the coronavirus on cancer care. Later, we shall hear from some of our diaspora who are leaders in healthcare. In Tanzania, Dr. Patricia Scanlon, a paediatric oncologist and indeed another UCD Alumni awardee. Before moving over to New York to hear from Mike Dowling, one of our North American advisory board members of the UCD Smurfit School, about the lessons he learned leading during the pandemic. Mike is the CEO of Northwell Health, the largest provider of healthcare in the state of New York, a previous epicenter of the disease. Mike and his team have recently published a book entitled Leading Through a Pandemic. At the end of the panel discussion this morning, we shall have a brief Q&A session, and we shall have limited time as we have a packed agenda. We shall only have time to address 2 or 3 questions for each session. Therefore, we are inviting each of our panel members to help us responding to some of the questions from our participants through the Q&A facility on Zoom. Before we begin proceedings, we would like to thank our conference partners, Roche, a global pioneer in pharmaceuticals and diagnostics focused on advancing science to improve people's lives, for supporting the technology we're using here this morning. We shall also have a coffee break at 11 a.m. this morning. And it is now with great pleasure that I hand over to my collaborator and co-host, Professor Mary Horgan, President of the Royal College of Physicians of Ireland. Mary.
Thank you, Geraldine. I'm delighted to be back in UCD, which is my alma mater. This is a collaboration between 2 learning institutions, UCD Smurfit School, who train people in business, and the Royal College of Physicians of Ireland, which is the largest and oldest postgraduate training body in Ireland. And we will learn from each other. I think what this conference is showing is the collaboration between different sectors, moving away from silos and looking at different people's perspectives on areas, on a pandemic, in this instance, COVID-19. So it's bringing together leaders in healthcare, in research, in business, but really importantly in our cultural activities, sports, charities, the arts, and really seeing what the perspectives they have of leadership in a pandemic and the challenges that arise from them. So I'm delighted to be chairing the first session, flying a plane while building it, or building a plane while flying it, I should say. And I'm going to introduce our 6 panellists. They are Dr. Ronan Glynn, who probably doesn't need any introduction. He's the Acting Chief Medical Officer. Dr. Colm Henry, also well known to most of the viewers. He's the Chief Clinical Officer within the HSE. Finbarr Kenny, who's Director of Roche Diagnostics in Ireland. Professor Paddy Mallon, a great colleague of mine, who is Professor of Microbial Diseases in University College Dublin and is a consultant in infectious diseases at St. Vincent's University Hospital. Dr. Nuala O'Connor, a friend and colleague. She is the lead in COVID-19 in the Irish College of General Practitioners, and Alan Sharp, who's the interim CEO of the Mater Hospital, a major teaching hospital in Dublin, and also UCD Executive MBA alumni from 2019. And the format it's going to take, I've asked each of the panellists to speak for 2 minutes without slides, strictly 2 minutes. And following that, there will be a Q&A, which I will chair based on the questions that come in. So firstly, I'm going to go over to Ronan, who is going to speak on challenging times and difficult decisions. Ronan.
Thanks very much, Mary, and good morning, everybody. You can hear me okay?
Yes.
Yeah.
Okay. So I'll keep it very short. You're certainly right that none of us envisaged we'd be where we were, least of all me, 7 or 8 months ago, but here we are. I want to talk about the importance of communication as a leadership tool for a quick 2 minutes, and some of the things I've learned over the past few months. We set out our stall at the start of this that we were going to communicate clearly, often and directly with people to make sure that people understood what we were trying to do and why we were doing it. We've tried to be clear from the start about who our audience is. It's not Twitter, it's not politicians, it's people in their homes around the country. And that informs how we communicate with people. In trying to communicate, we've sought at all times to acknowledge uncertainty. We've not waited until we have all the information. And I suppose at times that's been challenging because you do face a challenge versus other voices who speak with absolute certainty in the context of a pandemic where there simply can't be certainty. Equally, we have to acknowledge other views. We're not all seeing. There isn't a precise roadmap for this. None of us have done this before. We won't get everything right. We haven't got everything right. And there are very legitimate other views and ways of approaching things. That notwithstanding, we have to try and navigate a path. We've tried to be honest about current challenges. If you look back, for example, at the issues around testing in March and April, we have to be upfront and tell people we simply didn't have the capacity. We have to be upfront now and say that we need to continue to build that capacity and build all the other elements. To be clear about priorities and how the priorities evolve over time. So I think a clear example of that is at the beginning of this, a clear priority was to make sure that our healthcare system wasn't overwhelmed, that our critical care units weren't overwhelmed. And from that perspective, the health system cleared out beds, employed private healthcare to help out. This time around, it's slightly different. Again, of course, we don't want to get our health system to be overwhelmed, but actually the challenge now is to keep all of the other elements of healthcare going so that people with all other types of illnesses can be treated through the winter. So it is a different challenge and it's a different priority. And we just need to be clear about how that has changed over time. It's important in all of this to focus on the positives. There's been an incredible amount of positive things to emerge from this pandemic. In healthcare, we've seen, it's been mentioned twice already this morning, de-siloing across public health, primary care, infectious diseases, and across the acute, the entire spectrum of acute care. We've seen fantastic innovation in healthcare. Look at what was done around homelessness earlier in the year. We've seen fantastic innovation in the retail sector, in the hospitality sector. Look at how communities have come together around the country to support one another. Solidarity and kindness have been hallmarks of the Irish response. And it's important to remind people of those key elements of the response. And finally, in focusing on the positives, I suppose, a clear challenge for us all the time is to emphasize to people that there's so much we can do to protect ourselves and others, as opposed to things that we're not supposed to do. So the focus needs to be on the do's rather than on the don'ts. So I might stop there in the interest of time, but I'm happy to take any questions.
Thanks, Ronan. We'll follow up with questions. Next up is another colleague, Dr. Colm Henry, who will talk on running a health service where COVID is a component rather than its entirety.
Mary, thank you, and thank you to all the organisers for this very timely conference at yet another critical juncture in this seemingly endless journey through COVID. There's a famous political quote that was used at the beginning of this crisis, that there are decades where nothing happens and then weeks where decades happen, and it certainly seems decades since we had our first case here at the end of February. Our response then in the healthcare system and beyond in wider society was based on what we witnessed elsewhere in Bergamo and Wuhan. And it was a very singular response to flattening the curve. And we were allowed to have a singular response then because based on what we were seeing, there was an overwhelming sense of solidarity that we needed to flatten that curve and break that chain of transmission of the virus. And what we saw then was remarkable alignment of expertise, evolving scientific knowledge, and political and medical leadership. And this alignment was crucial to how we managed that first phase. It was dynamic, agile, allowed us to navigate our way through some very volatile times in the healthcare service, through changing case definition, working with Nuala and her colleagues, through outbreaks, the first deaths, through the difficulties with the testing regime. And now that we're at another critical juncture where we see a sharp rise in hospitalisation in cases across Europe, we now are no longer allowed a singular response, as Ronan says. We now are dealing with a population who are fatigued, hearing the same message. We now know the impact of the lockdown, particularly in vulnerable groups and the elderly. We're aware of the importance of reopening education and health. But two things haven't changed, and one is, I would say, the requirement for this alignment going forward. And part of that alignment is to ensure that expert public health and scientific opinion is not marginalised or even demonised. And some of you will have read Pandemic Century by Honigsbaum, which came out in a timely way, published earlier this year. And he refers through the plague in San Francisco, that is the bacillus plague, that the scientist who detected the bacillus found himself the subject of a vitriolic campaign led by the then governor of California, and it was proposed to make a felony to broadcast the presence of a plague. Now, we're not in that situation here, but it's important that we preserve, protect, and allow all strains of scientific opinion and expertise to continue to thrive, because without their innovation and knowledge, we're not going to succeed. Secondly, very at the end, is solidarity. This principle of solidarity is not only makes medical sense, but it's ethically required. It's not tenable or acceptable for us to say that there could be one set of restrictions for one set of the population who don't suffer from the virus, and to apply a much more stringent set of restrictions to those who are more vulnerable. And it has to remain a fundamental principle for all of us going forward, and that until a safe, effective vaccine comes in, that we not suppress the virus and continue strive to protect vulnerable and older people from, and not expect them to protect themselves. Thank you.
Thanks very much, Colm. Finbarr Kelly is going to talk about innovation and engagement. Finbarr.
Thanks, Mary. Good morning, everyone. So my name is Finbarr Kelly. I'm the Director of Ireland for Roche Diagnostics. I'm also representing the pharmaceutical arm of Roche here today as well. Just to begin with, thanks for having me on the panel. I think the title of the panel, Building a Plane While Flying It, is perfectly apt. A great analogy to describe, I guess, actually how we all felt at the start of this pandemic. As Roche, we were working in close contact right across the laboratory network from the beginning, working closely with colleagues, understanding what we were dealing with, how best to mount an appropriate and effective response, but also to ensure that we could supply medicines and tests where they were needed most. And this was the key. I think that, you know, the point that Ronan made earlier, global supply was totally outstripped by the demand right across sampling and testing, patient management and professional equipment. And so therefore we needed to think differently as to how we were going to work within a networked model of supplying testing and medicine in appropriate ways. For Roche's part, we looked at ensuring that we had the essential high quality, reliable tests and platforms in place across the HSC, across that network. But also what was important is that we needed to innovate. So with Roche, we, in the last 6 months, have brought 6 new COVID diagnostic tests to the fore. We invest more than any other company actually in this space. But we're also now bringing a rapid antigen test actually to the fore in the next number of weeks actually to Ireland. Important, innovation being that key. Also from a pharmaceutical side, this week we just published a study on a Roche medicine that with COVID patients, they are 44% less likely to progress to medical ventilation. What this really means is that there is an essential component within the response to COVID pandemic, which is a meaningful engagement between industry and the healthcare system and healthcare professionals. And within that dialogue, within that collaboration, we can see how we can best utilize our resources, create a proper network and strategize across that network to ensure that medicines, that tests are deployed in a conducive way. But also, I think, for us to be able to look at how we can then accelerate innovation into Ireland and potentially look at a model where we can decompress laboratory testing by deploying also into a community screening program. As director in Ireland, I'd speak on behalf of Roche to say that we continue to support healthcare professionals and patients as well, right across Ireland. We're very proud of what we've achieved and continue to achieve with the HSC. Thank you.
Thank you very much, Finbarr. Paddy, Mallon is going to talk about research and innovation, a means to an end. Paddy.
Thanks, Mary. I'd like to thank both yourself and Professor Doyle for the opportunity to speak today and for organising this conference. I mean, having spent 27 years now researching and working in a clinical environment with viruses, what we've seen over the last year really has been unprecedented, as the other speakers have said. And I think that we are entering a new phase at the moment with regards to research. We've seen a lot of different therapeutic advances being made and diagnostic advances being made in the last couple of months. And really what we need to do is to be able to rapidly translate these new advances into clinical practice. And some of these advances will have significant impacts in terms of how we manage this epidemic. So just going back to what Finbarr said about new medications and how we use medications for specific components of COVID-19 infections, such as that pre-ICU space with tocilizumab, which Roche have done some remarkable work on, together with new diagnostics to try and alleviate the pressures that are on our test and trace system. But aligned with that, I think that as we move forward from a research perspective, there needs to be, I think, an expansion and a collaboration of that research that goes beyond medicine. I think that as we continue to learn to live with this virus and we continue to pursue a strategy of living with this virus, the importance of involving research that includes economic research together with social science research on the societal impacts of the choices that we're making, I think is going to be central. And the other important component of research that I think all of the speakers have alluded to up until now is that it's natural when we do something new that we make mistakes. And I think that it's important that we learn from the mistakes, and the only way that you can learn from your mistakes to make your processes better is to have the appropriate investigations and the appropriate insight and that root cause analysis to be able to learn, to be able to improve. And by improving, I think that we will place ourselves in a much better position. As a physician, just going back to what Dr. Glynn said at the very beginning in this presentation, there are a huge amount of good that has come out of this. I think that even though we're in what seems like quite a dark place at the moment, we're working in a system that has, I think, completely revolutionized itself within the last 6 months. And we're dealing with a completely different form of pandemic, but we're also dealing with this pandemic within a completely different structure. And I would hope that that structure will be capable moving forward for us to be able to cope with the rising infections that are coming in the next few weeks. Thanks, Mary.
Thanks very much, Paddy. And next up, Nuala O'Connor, who's going to talk about collaboration and common purpose to implementation. Thanks, Nuala. You may be on mute.
So I actually, Mary, you had asked me, I think, a slightly different question that you had posed to me, Mary. So it was about how do we change the narrative from fear to caution so that our population and patients feel okay to present with other health issues and to manage their other health issues. So I might perhaps...
I was going to ask that for the question and answer, but that's okay. I think it was the collaboration around community.
Yeah, well, it's a bit of both.
That really worked.
Yeah, a bit of both of those things, I suppose. Well, I suppose, to me, I suppose, echoing one of the big things that came out from me with this was actually about that multidisciplinary approach and collaboration. And I think engagement with our communities, and by that I mean among the healthcare community and among the wider population. So I think the coordinated approach at national level between the HSE, the Department of Health, the Irish College of General Practitioners, and right across all of the healthcare system, I think was one of the key fantastic things that I saw, and that change and innovation and that can-do attitude, which I hope that we can continue. And we needed that because we needed to engage with our communities. And for that, what we need is consistent messaging. But also I would echo what Ronan says, that we need to be honest with people. And this is something we had to do. So we can be honest but at the same time, we can give people positive things that they can do and actions that they can actually take. And I think that was something that was really important. The consistent messaging to people is that there is something that everybody can do and they can continue to get on and to live with their lives. But in general practice, I suppose we were in that unique space where we are very close to our patients and also very close to our communities. And one of the challenges for us was to actually not only to manage the fear and anxiety among our patients, but actually to manage fear and anxiety among my own colleagues and to ensure that they were equipped to know that how they could practice medicine safely, how they could see patients safely. And because otherwise their fear and anxiety was going to impact on patients. And the other thing that we focused on really was reaching out into those communities. So reaching out, and in the early stages, very much reaching out to the elderly who were cocooning at home. And many of us in our own practice, what we did was we actually rang each and every patient over 70 years of age to see were they okay, did they have medicine, did they know who and how they could contact us. And we were also very conscious about things like immunizations in the early stage. We didn't want those to fall off, and people were very fearful. But the last thing we wanted was to have other outbreaks. So that whole reaching out into communities, I think, is really, really important. But I think overall, for me, the big thing that stands out in how we might actually, how partly of how we have overcome this is at national level, that engagement and that consistent approach coming across all of the healthcare disciplines. And I hope that's something that we can capture and continue to have moving forward, because it's amazing what we can do when we all work together and stay out of those silos.
Thank you, Nuala. And Alan Sharp is going to talk about repurposing a large level 4 hospital from the outset, being mindful of all the non-COVID activity. Alan.
Thank you. I'd like to thank you and Professor Doyle as well for the invitation, and all the panellists. I'd just like to start off and reiterate what some of the panellists have said, that the health system, and how it functioned during this first phase of the pandemic has been an example for us all. There's been a huge collaboration across every sphere, from the community into our commercial partners and into every level of the healthcare system. It's amazing to see, and when I talk about all the hospitals. The hospital is my own, I'll give an example of, but this happened up and down the country. We effectively run a 350 million euro business in the Manor Hospital. We operate off 610 to 615 beds, and we're 102 to 103% occupancy rate virtually the entirety of the year. And to be faced with having to turn a business on its head, it's unbelievable what it does to the people and the leaders around us. There was an agility that I've never seen before. And I've been many years in private sectors and some of the big blue chip companies. And what I've seen from the clinical leaders and leaders of every level within the business was unbelievable. We turned off effectively 7 wards in the hospital, which is about 150 to 200 beds. Some of those wards were repurposed within hours. So we had to reconfigure them, find alternative locations within 7 or 8 hours. We moved services to Kappa, to Blackrock, to Beaumont, to the Mater Private. We moved cancer patients into separate buildings to keep them safe. We locked cancer wards down. We turned digital systems on that allowed us to access 15,000 patients during the pandemic. We had estates guys making sure that the patients and the staff were safe. As equipment was being bought, the questions were being asked. The infrastructure cope with the number of ventilators we may have to run. So in every facet, our supply chains, our laboratories, there was change in almost every single space within the institution. We turned on our first COVID beds on the 3rd of March. On the 6th of March, we shut down the first big ward. And literally every 3 or 4 days after that, we shut a ward down. The support we got from the HSE with the tools we were allowed to use, the private hospitals were enormous value. And I know there's debate about the economic benefit, but I can tell you the operational benefit is unquestionable. Without the private hospitals, we would have struggled to provide care for the patients that we needed to provide it. We were able to continue and keep transplant moving forward within the hospitals. Some of the more serious cancer surgeries were all put on, were able to be delivered. So as we moved forward, what we actually have secured, and I hope we will maintain it long term, is that we've secured an agility and ability for teams to actually rethink every single process within the hospital, look at the current opportunity to streamline the system. And what we're finding now is we're finding the teams are coming back through the pandemic, and they're finding better ways to deliver services, ways that will make the patient journey better, which will provide efficiency within the institution. And this is not just the Mallon Hospital. I'm giving the example from where I sit, but I know from talking to colleagues up and down the country that it is in every single hospital this is happening in the state. And one of the key messages that we would put from this is it's when the layers of decision making shrink and decisions can be made quicker and solutions get brought to the table, and those solutions can get delivered much faster. So from the Mallon Hospital, our key learning from this was that there is agility in the public sector, and it can be used if we have the appropriate structures, and those structures were definitely supported by every part of the health system while we managed the pandemic. Thank you.
Thanks very much, Alan. We've got quite a number of questions coming in, so I'm going to put them to the panel, some of whom I will identify and the others can chip in. So the first question is from Wayne O'Connor. What do the panellists make of Ireland's contact tracing and testing regimes? And secondly, do you feel enough has been done to build on the programmes between March and the beginning of September, given the rapidity with which we had this to do? I'm going to ask maybe Nuala to begin with.
Yeah, I mean, I think it's easy for people to criticise from the outside, but I've been privy to a lot of the workings as this was built up and the challenges when we came across pinch points. And what I can do is say that there had to be something set up from scratch and rapidly expanded. And there wasn't a workforce there to do this. So a lot of people had to be diverted from other parts of the healthcare system. And what we were able to do was to set up quite a two-way communication process, because at the end of the day, patients tend to present to the GP with symptoms. That's how they get referred for testing, and then it has to go through the lab, the processing, the result coming back, us doing that for the patient, and the contact tracing happening. And we were trying to get that as fast as possible. We were working with software systems that didn't communicate or talk to each other, so it was a lot of two-way processes. And every time things ramped up, sometimes more pinch points would arrive. So there was an awful lot of two-way communication. And, sometimes, it would happen. I remember one weekend, suddenly everything got much longer. I was getting this back from GPs. I was able to connect over the weekend with the HSE, and within an hour we had discovered that what was the problem. There was one file which had 20,000 items of information in it had suddenly not transferred across, and that was what was happening. That was the glitch in the system. So and I suppose one of the things moving forward is that we've never properly invested in technology within healthcare. We've never properly, we have an e-health strategy, which I think has never really been realised. And I think in the after action review from this, I think that's one thing that we really do need to have moving forward, as well as obviously strengthening our public health system, because we don't have enough public health doctors, and we didn't. It's not something following previous, I suppose, the swine flu pandemic and other outbreaks like MERS and SARS-CoV, when there was a need identified for stronger public health, which was never fully acted upon. But if Ronan probably able to comment on that more further.
I'll follow up on that because it is complex end to end. It's many links in a chain that need to be strong. So I'm going to ask Colm Henry about moving forward, because clearly it got a lot of attention, testing and tracing, in the government's new plan. So, and resourced. So I suppose it is one of the key areas for suppression. Colm, your thoughts on that?
Yeah, clearly building on what Nuala said, we had to, when I look back at that first case I was involved with, a child who was the first case detected mildly asymptomatic. The test we had to export to abroad. The child was kept in hospital for several days pending the result. And from that starting point, we had to build our own capacity, improve our turnaround times, and to the point where we've now just passed over that millionth test milestone, which is significant. We have 33 testing centres. We're on the constant increasing expectations about turnaround time and having to respond to that quite appropriately. What I would say, there were two critical components to what we've done to date. We've had to be agile and responsive, and we were at all times led by public health requirements, because the test, after all, triggers public health actions. It's not an end in itself. And the second thing, a critical part, was we were involved in primary care at all times, and they were remarkably patient and collaborative with us at all times, despite at some stages rapidly changing case definition, which threatened to overwhelm out of hours GP. People may forget, but one weekend, a changed case definition on Friday led to a crash of the 999 and out of hours GP calls. And so behind the scenes, there was a huge amount of collaboration. What I would say going forward, Mary, is we have to continue to be agile and responsive and meet the expectations, especially as we reopen education and health. But those two fundamentals remain in my view. That is, that it feeds public health requirements, because it's their tools, it enables them to carry out their actions. And secondly, that primary care it remains central in the governance of a testing regime, because remember, we can't develop and maintain diagnostic tunnel vision. There are other illnesses, some much more serious, that can happen, that can people will feel they can ignore because a COVID test is not present. So I would say those are the two components that we need to work on in our agility in the months ahead.
Thank you very much. There's another question from Nessa Childers, and it's for Finbarr, I think. It's in relation to social cohesion. Will there be a cross-sectoral consultation on the criteria of a vaccine? Kind of hard one, because some of that is policy, but as you know, we're a country that wants to treat everyone equally. So how do we do that?
I think I'll just give the perspective from, if I answer that question from a diagnostic perspective. The vaccine, of course, obviously is still being worked on by many different sectors within this industry. For us, we obviously need, and I won't talk about policy, but rather more on enablement. It is important, of course, for us to understand the through output or outcome of what a vaccine is going to have within the population. Those studies are still ongoing. What we can say is that we're working now on quantitative antibody studies and quantitative antibody tests to ensure that we can support any vaccine program that will emerge. There are countries that have engaged in vaccination programs right now, and we're watching those with great interest. Roche, for its own part, will be supporting from a diagnostic perspective what we can do on the vaccine, not just for antibodies, but also antigen tracking. I'm not sure if I've answered that question sufficiently, but I wouldn't be wanting to sort of sail too close to the policy question if that is the case. I think that's really a subject for the HSE.
Yeah, I suppose we went from being everyone in it for themselves when it came to PPE and vaccine diagnostics, every country for themselves. We should have a more global approach, but obviously we need to look after ourselves too. I'll probably add a small bit more to that, not just on the vaccine, but maybe also on innovation, if I just simply take that one forwards as well. And it might actually build also on what Nuala and Colm actually had said just previously. You mentioned the term about silo thinking at one stage, but I think it's important that we're not innovating actually within silos. And what we can see is that this isn't just simply a response as where we started going back to February and March time, where we were dealing with a network that actually wasn't capable of handling a pandemic. And so therefore it was massively scaled from March right through into where we are now to be able to handle the test numbers and the demands that were being put on the laboratory network.
What we are also seeing, of course, is the need to then extend beyond the laboratory and into the community. And this is actually what we're seeing, obviously, within the rhetoric, but we're also not just actually seeing where test capacity needs to shift, so we can also move resources. We also need to see how we can connect that back into an IT infrastructure. And digital health, along with the ability to spread resource between laboratory and community, are becoming one of the bigger topics now that we believe is in the need for focus and the need for innovation. The support from industry and the dialogue with industry, therefore, is paramount as the HSE is starting to look at how we can expand on both vaccination programs, test efficient test within the community, but also to ensure that we can connect this back into an intuitive track and trace mechanism. So I think innovation cannot occur within those silos, but rather to ensure that we're actually spreading that across multiple different sectors, digital, laboratory, and community.
Thanks, Finbarr. The next question is for Paddy, and I'm going to add in a question, an additional question. So this is from Sharon Foley. To what extent is the current low rate of ICU admissions due to better proactive treatments as opposed to severity of disease? And it appears to the public that the level is rising, but not as serious. That's the first question. I'm going to add in, how should we resource interrogation of the data that we have already on all those tested positive, so we can really plan on the various things like vulnerability, on where clusters are happening or where community spread is happening, so we can really be on top of this. So those two questions for Paddy.
Thanks, Mia. They're two very different questions. I'll take the first one. And so I think that what we're seeing definitely is a different demographic presenting for hospital care so far during the second wave than we saw in the first wave. And I think largely, I'm hoping that's largely due to the fact that our society has learned to protect themselves, especially the more vulnerable members of society have learned to protect themselves from acquiring this virus. So, and that really means that we're ending up with a younger population that are coming in sicker, and therefore the numbers are lower. Now, you don't want anyone to be sick, but it's an encouraging trend in terms of the fact that it's different from earlier in the year. We'll end up with less mortality, hopefully, as a result. We're getting better at managing. We have access to appropriate medications. We have access to results of phase 3 studies that have shown how to use some of these medications, but also, importantly, how not to use medications. We have a well-primed ICU system. We also have a well-primed pre-ICU system. So the treatments that are available for us, and when I say treatments, it's more about the medical management, not just medications, I think is going to translate into a lower ICU admission rate and hopefully a lower overall mortality rate. And I think that communication piece needs to be fed out there. It's not as if our health service is shut down. We've done actually a fantastic job. The HSE's done a fantastic job since the end of the first wave in trying to get everything open again. And the key here is that as we get these new cases coming in, to try and ensure that we're still operating our other health services and still trying to return to normal health services, because that is vital. As Colm has said, we can't have a scenario where people are suffering from other diseases because of this silo focus on everything being COVID. With your second question, really this comes back, I think, to learning from your mistakes and understanding this virus within the community. And the nuance of understanding the transmission within the community is understanding transmission networks in as much detail as possible. And I think from an infectious diseases perspective, getting back to that root transmission activity and understanding it in a granular form in every detail that you can actually help you understand why a virus transmits within a society. And it's that fundamental understanding of why someone, for example, takes a risky activity, where they take that risky activity, and why it perpetuates despite a knowledge base that tells them not to, is fundamental to community control. And I think that we need to, we as a research perspective, which I think will quickly translate into policy, we need to be taking a section of these community transmission cases and really delving deep into them to understand within Ireland what has got us to the position that we're in, because that will help us to form more effective interventions moving forward.
Thanks very much, Paddy. I'm going to ask Ronan about how we're going to, how we as a group about the next real challenge. This is from John, who's watching from home. The next real challenge in this pandemic is not simply the devastating effect of the virus, but the indolent threat of complacency. Your thoughts on that?
Sure, Mary. First of all, complacency isn't surprising, given how long we've been having to deal with this now, and I think equally people are looking at a winter ahead, and it's not surprising that people are really wondering how we're going to navigate through it together. I think to Paddy's point, a key part of overcoming complacency is that people will have more and more information at a local level. So from that perspective, there was new maps published yesterday at a local electoral area level, and they're on if people Google the COVID-19 dashboard Ireland, they should find them fairly easily, and it gives quite a granular level of local area data. But I can tell you, after the week I've had, I can promise Paddy and everyone else, my first priority going in next week is to set up a study or a process to better understand what's happening with confirmed cases who are classified as community transmission. This is not a challenge that is unique to Ireland. Most countries are struggling to fully understand where at least a proportion of their cases are arising. But we certainly need to do better in that regard, and then to be able to use that information to help people to make safer choices. I mean, it comes back to key fundamental of health improvement and health and well-being and the approaches we use in that sphere. So you have to make the right choice, the easy choice, and a key part of that is that people understand what making a choice easier is that people have the information, understand what an easy and safer course of action is versus another. So over the winter, I think it'll be about providing more information, and equally, I would like to think that it'll be somewhat less about, so obviously that the communication will continue from the centre. But I think increasingly we need people at local level, medical leaders, public health leaders, local representatives, using the information that's available to them and communicating. So as we sit here this morning, I have concerns about Louth, Donegal, Waterford, Limerick. Cases are still high in Kildare. It's virtually impossible for me to communicate on every local radio station, in every local paper. We need people in each region monitoring the data and coming out. The messages are not difficult. It's the simple, it's the basic messages, and they haven't changed from the start. And so really I'll be pushing that message over the coming weeks, that we need local people that local communities identify with, coming out and expressing the importance of these messages, as well as local businesses and local organisations, because it's in all our interest to keep this low so that we don't go up the levels as we go through the winter.
Thanks very much, Ronan. And Aisling Murphy had a similar question. It was on, solidarity was easier in the beginning of the pandemic, and as leaders, how you were managing to balance the changing public sentiment with communicating your message. And I suppose I've been an advocate for a lot of localization of the messaging, the testing, because locally we know how people live. So that certainly is really welcome. I'll ask Alan Sharp a question on if you just pick one biggest challenge going forward from September for the next 3 months in your hospital, what is it?
Okay, thank you. I'd say the single biggest challenge we're going to face is staffing. We know from the first round in COVID, there was a particular point in time where the hospital had 450 staff missing from the institute. If you look at the complications that are going to be there when we go into the winter, you're going to have, the schools are now in full swing, which is, we're very supportive of. The rules associated with sending children home and quarantine is going to create huge difficulties for staff. On one day alone last week, we lost 10 ICU staff. So as we move into the winter, our staff numbers are going to be put under huge pressure. So even if we manage to keep COVID down, the flu and all of the other difficulties we deal with during the winter that have to be treated as potentially COVID patients. Well, they go up into individual rooms to be separated. If the staff have to wear PPE, so up on the wards, our staff are having to be increased on those wards managing the query patients. The COVID patients also will need additional staff to manage. And as that's being impacted by staff who may be infected in the community themselves, so we will have some losses of staff. Obviously, this time round, we've learned lessons from phase 1. We're just about to introduce, we're going through how to introduce staff wearing masks everywhere in the institution to try and keep them safe all the time while they're in the hospital, and we're following national guidelines in that regard. But I would say the single biggest concern moving forward is being able to have enough workforce on the ground capable of managing the patients safely that need to come in without having to start to cut back the services that the non-COVID patients rely on. So that is our kind of our major focal point at this point as we move into the
Thanks very much. I'm going to ask a question, and it probably is for Ronan, Finbarr and Paddy, and it's about international collaboration. I suppose I'm just talking about looking at things. There seemed to have been maybe a lack of collaboration, certainly in the EU, and I feel I'm part of an EU family. And maybe beyond. So is there a plan to strengthen collaboration? Research is probably not too bad, and probably diagnostics and therapeutics, but that kind of policy and the communication message, our ability to perhaps travel between countries. Ronan, from the government department health point of view, how strong is the collaboration? What lessons are the good and the bad things that we can learn from our European colleagues?
I think that the key lesson over the past 8 months is that different countries have different perspectives and approaches, both in relation to travel, in relation to levels of risk that they're prepared to tolerate, and the general approaches they've taken to testing and tracing. That said, I mean, there is a high level of collaboration at European level through the ECDC, and indeed with the European Commission now as they try to develop a travel policy which our own government has indicated it's going to broadly support. Of course, that needs to be finalised. I think that the particular area of collaboration that's been welcome and that is progressing at speed is around COVID vaccines. And so there's very significant work ongoing at European level to ensure that all countries across the region have equitable access to vaccine based on their population size. And so we've been heavily involved in that over the past number of weeks in particular.
No,
leave it there in the interest of time.
I'm going to ask Finbarr to comment quickly, and then I'm going to come back to Nuala with a question on local engagement. The international collaboration, I know research-wise it's good, Paddy. Finbarr?
I would say, I'll start with a very basic tenet that no one company is going to solve the pandemic, and therefore it's most important that there's an industry-wide collaboration right across Europe with governments, with healthcare systems, in order to best understand country by country, but also European-wide, how best to manage, contain, track and trace, but also deliver on the vaccine program and the follow-up preventative measures. What we have seen very successfully in other countries is where there's an open, collaborative dialogue between government and industry leaders such as Roche to understand exactly what is possible, what's possible now, but also what's actually being innovated and actually what's in the pipe, so that this can be best incorporated as quickly as possible into the pandemic strategy. That ongoing dialogue, I think actually, and we are seeing this in Ireland, is part of the reason why we have progressed actually beyond the laboratory and now looking at potential for community testing. It's also the potential for us to be able to accelerate towards an effective vaccine program. So ongoing dialogue, and I think a very open forum, is something that actually industry leaders are crying out for here in Ireland with the Irish government, the Department of Health, is a key component of how we can actually innovate our way and stay ahead of the pandemic.
Okay, thanks, Finbarr. Paddy, one brief, and then I get on to Nuala probably for one final question.
Just very briefly, I just wanted to highlight SANS Foundation Ireland during this pandemic. There's a huge amount of basic research going on right across Ireland that has been funded through 2 calls now that have been brought up by SANS Foundation Ireland. And what's brilliant about these calls is that they have been well funded. They've been a very fast turnaround, but with robust peer review. And they've been rapid calls for research that's bringing results in within 3 to 6 months. And I think that it's probably something that's not talked about as much at the national level, but it really is one of the big success stories of the years of investment in research infrastructure across Ireland, that we have that breadth of research going on at the moment within the country.
And Paddy, do you think that, I mean, the UK were able to ramp up their research network very quickly because they have a really strong inter-university, inter-institution collaboration that I think could be stronger in this country? I mean, do you think there should be a direction from the new Department of Higher Education by our former Health Minister, Simon Harris, to bring that collaboration together and really have it stronger rather than competing against silos to collaboration?
I believe that the UK were able to escalate to the point where they were able to do large-scale population studies was largely based on an interconnected network of research between the research funders, for example, RHRB and SFI, and their health system, the NHS. And I think that what they demonstrated by that investment is coming out within the large phase 3 and adaptive design trials that they're publishing at the moment. So I think if there's a big lesson to be learned from our perspective moving forward, it's that collaborative approach that we've been talking about during this session. If that can extend into research, particularly the clinical research space, and build, we'll be in a much better position moving forward. And I think that's something that we can realistically achieve.
Thanks, Paddy. Nuala, you know, you're really on the front line, and you know your patients. You know who to worry about, you know who, maybe has difficulty in following guidelines, but you know who's isolated, who's stressed out because they're losing jobs, anxiety and all of that. I mean, there's a lot of unintended consequences of COVID and its impact on our population. And that local engagement that Ronan spoke about in its many aspects. What were your thoughts on that?
Well, I think it's really important. And I mean, if we look back and we think, well, how did we get in control of the first wave? And really, it wasn't really about anything that any of us here did. It was because every single person in Ireland took responsibility for their actions, and they took those simple things, the maintaining the distance, washing their hands, a good cough etiquette, avoiding, reducing their social contacts, avoiding crowded spaces. And I think, there is a bit of a sense that we've lost the public a little bit. People are tired of it. So one of the things in terms of engagement that we're trying to do within the Irish College of General Practitioners is we now have a team of 30 doctors to go on local radio, local media, local messaging with all those sort of simple things and those simple messages. But the other thing is through our network of GPs engaging with patients the whole time on the ground. It's all about reaching out to those vulnerable populations. I mean, the amount of people we're seeing with anxiety and mental health issues at the moment is huge. Our elderly population, they're becoming deconditioned. They're getting isolated in their homes. They're more inclined to falls and trips because they're not exercising, they're not getting out. Apart at all from getting people to actually not to ignore their normal other health problems, because we know people are presenting late. So I think there's a huge amount of a local engagement that we need to strengthen and get back to with all those simple messages. And one of the things when you talk about the collaboration with industry, I'd like to commend all of our broadcasting agencies, because they've given us tremendous airtime, and allowed us to counteract fake news and to continue to get that consistent messaging out to people to reduce fear and anxiety and allow people to come forward and to access healthcare. So I think encouraging people to come forward and access healthcare, but also empowering people as to what they can do to keep themselves safe and to continue to live our lives, because we're going to be with COVID-19 for quite some time to come.
Thanks very much, and I would agree with the media have been really good at allowing us to get simple messages that cross consistently to our people and really acknowledge all the work that they've done to date. I've got a question for Colm. Henry, we're just running over a little bit because we've got a number of questions. Yeah, okay. Just the last question from Fidelma Fitzpatrick is the change to our approach to keep non-COVID healthcare going. Our colleagues are tired and she feels that we need to tweak our communication. What bits of your leadership style will you keep and what will you change as we enter the winter season? That's the final question.
Thanks, Mary, and hello to Fidelma, who is a great communicator herself in her infection control in her own leadership position at HSE. It is more difficult. The message in the first phase was blunt and crude and simple. Flatten the curve, and we cleared the decks, we cleared hospital beds. We now know the great harm that was done to children and to older people as a consequence of the lockdown. And we don't have that comfort zone anymore of singularly focusing on COVID suppression alone. That calls for a more difficult messaging, it calls for more difficult leadership, and it calls, to my mind, it means we have to focus on that bit of the message we had, that it's not just suppressing the virus, it's protecting vulnerable people. Centres to hospitals, and these are the people who are, statistics show are affected most severely by that. So to go back to what I said about 2 words, Mary, I think it's not morally, ethically acceptable for us to expect older and vulnerable people to protect themselves. It's part of our whole mental spirit. It's our combined responsibility to drive this message and to enforce it with our communities.
Okay, thanks very much, Colm. I've just probably the last question, because we'll wrap up after that, but this is really important for the future and the hope, and it's probably for Finbarr, Paddy and Ronan. It's about time scales for vaccination. When do you see, I mean, is it going to be a vaccine of eradication or a vaccine that will alter it, or maybe a combination? What are the timelines, do you think, for a safe and effective vaccine? Will I do Paddy first? And then Finbarr.
So I think the general consensus is that phase 3 studies will start to come in towards the end of this year. And you're right in terms of the devil will be in the detail of the phase 3 studies, because there's 2 broad approaches to vaccination. You can have a population approach, which is where you're looking to sort of eradicate this virus, or you can have an individual approach. And for an individual approach to work, as Colm said, the focus needs to be on the vulnerable people. So therefore, you need to ensure that you have a vaccine that is effective within that vulnerable population. So we need to see the phase 3 study, see how the vaccines work, see in which populations they work best, and then translate that research into a policy perspective. And I think that's why, colleagues around the world have been saying, okay, there may be a phase 3 studies coming in late this year. There'll be production issues. There'll be policy issues in terms of how we use the data to implement the research within a population. And I can see that it taken well into next year before, if we do get a vaccine, before we'll be in a position with the knowledge to be able to use it effectively.
And Paddy, based on the information we have so far, how confident are you that we'll get a coronavirus vaccine, given that it hasn't happened before? Now, I'm an optimist, so I always think we'll get something. We've lived through other pandemics where we can't eradicate it, but we can certainly control them. So I know you're an optimist too, otherwise you wouldn't be in research.
Yeah, the scientific effort being put into this is unprecedented, and the difference between this approach and previous coronavirus vaccine approaches is that we're not just using one standard scientific pathway, picking an adenovirus vector and trying to get an immune response. I can think offhand of 5 different scientific pathways that are being used that are all very distinct and all very different to try and induce a vaccine response that has neutralizing capability. So with that sort of effort and that sort of innovation, I'm very hopeful that we probably won't get one vaccine. In fact, we may get several different vaccines, and the challenge for us will then be trying to use them appropriately. The one word of caution though around vaccines is that we need to ensure we have the full data set available before we start widespread use of vaccines within a population. And we need to ensure that the vaccines are not only efficacious, but that they're safe. And that's going to be critical moving forward.
And Finbarr, can I just ask you, kind of related to that, really rapid testing? Like, we know we can do it, but it's in a very small portion because of reagents and all of that. But the ability to do a rapid test at home, be able to travel for work purposes, or, you know, prevent the restrictions that are coming in, like, how quickly will that happen? I can get a test, a saliva test at home, pop it into like a pregnancy test, and get my result with, I mean, it's not going to be 100%, but with confidence.
So patient sample matrices are obviously changing right now, and the moving from pharyngeal to nasal and now to saliva is very much in motion. So rapid testing in order to support an effective track and trace mechanism in the community, but also to check the efficiencies of the vaccination program to determine whether people are indeed actually infectious. And that in combination with a quantitative antibody test is definitely where technology is moving. As we're going to see an emerging vaccination program, it is still important to keep a track and trace mechanism going in parallel to that. COVID's going to be with us for some time. And as we're looking towards evolving and introducing rapid testing, we'll see no doubt introduction of saliva testing, potentially at airports, potentially actually within the primary care setting. And this will be fully supportive then of the vaccination program. I think that combination of diagnostic and therapeutic is how we'll probably stay ahead of the pandemic.
Okay, thank you. I think we've exhausted all the questions. There are loads of other questions that we just can't get to. I appreciate sharing your expertise with us, given how involved you all have been in the pandemic, and particularly in the past few days, acknowledging Ronan's work, given that, you know, everyone has a life outside work too. We need to be mindful of that. So again, thank you for taking the time on a Saturday morning to share your experience.